So I've been asked to talk about top tics while performing a pediatric keratoplasty. Sorry, bear with my bad throat. Do not have any relevant financial disclosure. If you look at, this child is around 10 months. So you have that classic blind look. The moment you restore visual access, you can actually see the visual behavior and the trajectory, the entire development, both sensory and motor in a child. It's so rewarding, that painstaking ability to do perform keratoplasty in these children is really worth at the end of the day when you look at. And when it comes to pediatric keratoplasty, it is not simple miniature eye which we are dealing with, and there are numerous technical complications one would encounter. It is at least have been documented 10 folds higher technical complication one tend to encounter during the pediatric keratoplasty. So we need to have a very distinctly all these factors are equally very important. To me, establishing diagnosis is the most important. As Karan said, some of the diagnoses have extremely good outcome, and many of them do not have a good outcome. So the establishing diagnosis is a key which determines the anatomical success. And visual potential, it could be due to many other reasons apart from amblyopia. It could be vitreoretinal or even a CVI, certain other issues can directly impact. So this determines the functional success. You may have a clear graft, but child may not have a vision. So we should not end up in this particular scenario. And also assessing comorbidities, if they have a concurrent glaucoma, cataract, or any other vitreoretinal abnormality or a lens issues, this again affect directly the longevity of the graft. Any subsequent surgery is a big, hit on a graft. It may end up having trigger the rejection process or take away whatever that minimum number of endothelium present. So therefore, it directly affect the longevity. How long the graft survives is purely based on how clean the eye is. And most important factor, what we found out is social status, not necessarily economic status of the family. How committed family is for the rigorous post-operative care during the visual rehabilitative journey. The mother may be she may be uneducated, she may not have a financial freedom, she may have additional children, to she has to take care unless she has that organizational skill to instill, every hourly steroids in the initial phase is not easy. And also picking up, there are many complications one get to see, be it premature loosening of sutures, suture-related infections, or even a rejection, for instance. It has been documented 3/4 of the rejections are irreversible in a pediatric age group. So as my friends already have covered, explicitly very well what are all the preoperative determinant. In a pediatric, in addition, UBM is the key. This helps in actually accurating, pinpointing your anatomical diagnosis. It's a mathematics now. You know the diagnosis, you would know the long-term clinical outcome and functional outcome. You can directly communicate to the patient. In some of those sclerocorneas, which are extremely poor prognosis, I'll be coming to shortly, we have a surrogate marker in terms of assessing the number of palisades per every square millimeter. This also add to the functional outcome. Apart from assessing the VEP, child visual behavior, and in a very rare circumstances, we may embark on a diagnostic endoscopy if you believe child has a vitreoretinal or optic nerve issues. And as I was talking, it's just not simple anatomical small configuration. Cornea is more pliable, and all of them need a technical modification. As some of my colleagues were covering, it should be hypotensive anesthesia, reverse Trendelenburg position, and wherever applicable, mannitol. Mannitol, I tend to give a bolus 1/3 and 2/3 is a slow, so that you would achieve that hypotony which is really needed. And of course, while applying a Fleringa rings, one has to be extremely careful. Some of these scleras are extremely thin and vulnerable for a perforation. And one has to decompress extremely slowly, so has to minimize the suprachoroidal bleed. That can be a devastating complication. One of the important reasons for the expulsive hemorrhage is arteriosclerosis. He is hypertensive. People on some of the anticoagulant blood thinners. These are all the potential risk factor. If any patient had other eye expulsive hemorrhage, there is a 90% likelihood that we end up having expulsive hemorrhage. And in some of these cases, I do something called a sandwich technique. If the time permits, I can discuss with you offline. So the sandwich technique also minimizes the risk of lens touch and also some of the potential complications. Post-operative is equally important. And as I said, in these children, some of the sclerocorneas, within 4 weeks, we may have to remove all sutures. And as I said, resection is almost 3/4 of them are irreversible, and one has to be extremely careful. So is astigmatism. Just keeping the visual axis clear is inadequate. We have to give a appropriate optical correction and also institute amblyopia therapy. Although last 30 years, there have been an increasing result of pediatric keratoplasty. Otherwise, way before 1970, pediatric, PK, if you look at any textbook, it is contraindicated. And thanks to many of the pioneers, they have actually helped, achieve a good outcome even in these children. And these are the certain complications. And a long run, if you look at, so prognosis is abysmally poor for a certain cases. Something like a CHED in South India, which is much more commoner, tend to have a much better visual prognosis. Again, a repeat keratoplasties tend to have a poorer outcome. In a repeat keratoplasty, I do, institute, immunosuppression. I can talk about topical and systemic, outside this class if necessary. I'm just giving you one example, Karan. Maybe I'll take 2 more minutes. So this is a sclerocornea. You can see I've imaged this limbal palisades, and one of the thing is if we have a more than 5 palisades for every square millimeter, so that helps in maintaining the post-operative epithelial homeostasis and milieu. And cases which, so for instance, right eye didn't have a palisades. We could, measure only 1 or less than 1 inconsistently, and left eye had a 1 quadrant of limbal palisades, were more than 6. So I started with a left eye surgery, and this is a new technique which we are describing now, limbokeratoplasty. So what I essentially do is these cases which do not have a limbal palisades. This is a sclerocornea. They have a poor limbus, and entire cornea is filled with deep stromal vessels, and you have an extensive pus formation. One has to be very careful. And only modification I'm doing it, if you look at this donor tissue, these are less than 40-year-old having a 6-hour DPT and should have at least a 1 quadrant of a healthy limbus. And this is histopathology, all high risk factor for a corneal grafting, including there are no endothelium here. And look at these children. They tend to do extremely well. It's very rewarding. And this child has completed 16 years of follow-up. And of course, we have to put them on immunosuppression. You can see post-operatively, I have put a specialized contact lens to minimize the suture-related complication. This child, in between visit, lost the torsorrhapy and a contact lens. In a 1 week, you can see a drastic difference between right and left eye. Okay. So even such cases, sclerocornea have a 100% failure at the end of 1 year. So with this new technique, we were able to achieve 10-year outcome about close to 80%. So I finish here and I'll go to directly. So as I said, early detection, correct diagnosis, and recognizing ocular or systemic comorbidities is a paramount in not only maximizing the success of the graft and also functional outcome. Imaging helps in pinpointing accurate diagnosis. One has to tailor-make surgical innovations, so help to achieve a good outcome in these cases. Sometimes it could be simple optical iridectomy, rotational graft, or a SEPA, and post-operative care is the most important than a corneal transplantation. So less with this new innovations and meticulous care will disprove the dogma which exists. The pediatric keratoplasty otherwise tend to have a bleak prognosis. So we can actually change that dogma, question it. Thank you so much, Karan.